Hi everyone, welcome to another episode on the USMLE review series. Today we'll be looking at renal pathology and discussing the topic of acute and chronic pyelonephritis. So in creating this video, I've used your first aid for the USMLE as a guide. I've ensured that all of the information present in first aid is included in these lectures. And there's also additional information that I'm including so you could have a better appreciation of the topic. So if you like my work, if you find my videos very helpful, you could support me by liking this video and subscribing to my channel. Alright, so introduction to pyelonephritis is pretty much an infection of the patient's kidney. So it's a common kidney disease characterized by inflammation affecting different parts of the kidney, including the tubules, the renal interstitium, and the renal pelvis. There's two main forms. We have our acute pyelonephritis, which is typically due to bacterial infection and is associated with a lower urinary tract infection. Technically, pyelonephritis is a urinary tract infection, but it's considered a upper urinary tract infection. And then there's chronic pyelonephritis. This is a complex disorder, and it is usually as a result of recurrent episodes of acute pyelonephritis. Bacterial infection is prominent, but the patient may have underlying chronic pathologies like pre-existing vesicoureteral reflux, urinary tract obstruction, and all of these could contribute to recurrent episodes of pyelonephritis, which could lead to chronic pyelonephritis eventually. All right, so some risk factors for the development of acute pyelonephritis. And these risk factors are important for you to know because they're present in your first aid book also. Um, Urinary tract obstruction, that is going to lead to stasis, and that's going to lead to colonization of the urinary tract, which may lead to pyelonephritis. Instrumentation in the form of catheterization could introduce organisms into the urinary system, leading to pyelonephritis. You have your vesicoureteral reflux, which is going to lead to the reflux of urine back into the ureters and eventually into the kidney. Pregnancy is a risk factor too, and it predisposes to bacteriuria, which could lead to pyelonephritis. And that should be treated promptly, especially in pregnant women. Gender and age. Pyelonephritis is more frequent in females due to the shorter urethra, around up to 40 years, but the incidence increases in males with age due to the issue of BPH, prostatic hyperplasia, which would cause urinary stasis again, urinary obstruction and stasis, and could predispose to pyelonephritis. Pre-existing renal lesions like intrarenal scarring, obstruction, um, this could facilitate the growth of microorganisms and um, bacteria by acting as a nidus for proliferation. Diabetes, high glucose levels would increase susceptibility to infections, so that increases the risk for pyelonephritis. And we do see an increased incidence of pyelonephritis in diabetic patients. Another reason is um, patients with diabetes could have autonomic neuropathy, and that could lead to a neurogenic bladder. And that would lead to stasis, which is going to predispose to pyelonephritis. All right, so UTIs, so typically the organisms that typically cause a lower urinary tract infection would be the organisms that would typically cause pyelonephritis. So over 85% of the cases are caused by gram-negative bacilli like E. coli from the intestinal tract, predominantly E. coli followed by Proteus, Klebsiella, and Enterobacter. Other pathogens may be involved like Streptococcus faecalis and Staphylococci, also from the enteric origin. Um, Various bacterial and fungal agents can also cause UTIs, which could lead to pyelonephritis. If we see some sort of granulomatous inflammation, If it's caseating granulomatous inflammation, think of mycobacterial organisms like tuberculosis. And if we see non-caseating granulomatous inflammation on pathological specimen, we should think about fungal organisms as causing the infection. Special cases, immunocompromised individuals, patients who have HIV or organ transplant recipients, they may be susceptible to viral reactivation infections. So viruses such as poliomavirus, cytomegalovirus, and adenovirus might be the cause of pyelonephritis in those patients who are immunocompromised. All right, so the routes of bacterial infection to the kidney could occur in one of two ways, either the hematogenous route, which is a less common route, and the bacteria would reach the kidney via the bloodstream. And then we have the ascending route, which is more common. Bacteria would ascend from the lower urinary tract up to the kidney. Um, the hematogenous route results from seeding of the kidneys by bacteria from a distant foci, either during septicemia or if the patient has localized infections such as infective endocarditis. So, for example, if a patient has infected heart valve, like the mitral valve, um, it could embolize, travel via the bloodstream, reach the kidney, and cause either pyelonephritis or it could even cause renal abscesses and it's more likely in the presence of ureteral obstruction and a debilitated patient. And the organisms that infect the kidney hematogenously would typically be non-enteric organisms like staph, certain fungi, and viruses. It would make sense that the ascending route would involve more enteric organisms and the hematogenous route would be non-enteric organisms and is more commonly seen in patients receiving immunosuppressive therapy. All right, so this is just a diagram summarizing the pathways of renal infection. So we have the ascending route involving enteric organisms. It would make its way up to the bladder, then to the ureters. There might be pre-existing vesico-ureteral reflux, and it reaches the kidney, where it could cause pyelonephritis. Then we have the hematogenous organisms, which is going to reach the kidney via the vascular system, so via the aorta to the renal arteries, and that's where it would infect the kidney, causing pyelonephritis. All right, so the steps for renal infection, we first must have colonization. So coliform bacteria colonize the distal urethra and introitus if it's a female patient and is influenced by bacterial adherence, so urethral mucosa epithelia. So on some bacteria, they have a few virulence factors that enable them to colonize the urethral cells and the urinary tract really well as compared to other bacteria. So that's why E. coli is the most common organism that usually causes UTIs and pyelonephritis because of these virulence factors. So they have adhesins on the P. fimbriae, the pili of the bacteria, and they interact with receptors on urethral cells. So entrance of organisms from the urethra to the bladder. The organisms can also enter during urethral catheterization and it's usually seen also in patients who would have catheters in place long term. There is a gender disparity in urinary infections. It's usually more common in females for reasons females would have a shorter urethra. Um, there's absence of antibacterial properties in prostatic fluid in males. Females also undergo hormonal changes which affect bacterial adherence to the mucosa, and the urethra suffers trauma during sexual intercourse that predisposes to UTIs, eventually to pyelonephritis. That's why the incidence of UTIs and pyelonephritis is more common in female patients. All right, the lower urinary tract is usually typically sterile. The ureter, the bladder is typically sterile, more sterile than the um, urethra. and continual voiding and antibacterial mechanisms would usually clear organisms introduced into the bladder. If for some reason there's obstruction and stasis of urine, that would promote the proliferation of bacteria and cause UTIs. So some causes of lower urinary tract obstruction that could predispose to UTIs, we have BPH, which is a common condition in elderly males. Tumors could cause the compression. Kidney stones, calculi could cause urinary obstruction. And the neurogenic bladder, um, as a result of diabetes or spinal cord injury, could cause obstruction and predispose to UTIs. Alright, so vesico-ureteral reflux is commonly associated with acute and chronic pyelonephritis, so it's worth talking about this a bit. So the normal ureteral insertion into the bladder is a one-way valve that prevents the retrograde flow of urine when intravesical pressure rises during micturition. So when someone passes urine, the bladder pressure increases to expel urine. Usually, this should compress the urethra to prevent the backward flow of urine back into the ureters. So an incompetent vesico-ureteral orifice allows the reflux of bladder urine into the ureters. So in vesico-ureteral reflux, the intravesical portion of the ureter such that the ureter is not compressed during micturition. So that allows for the reflux of urine back into um, the ureters. So this condition is estimated to affect 1 to 2% of otherwise normal children. So this is just a visual representation of vesico-ureteral reflux where there's normally it should have a forward flow and a one-way valve should be present here. Um, but in vesico-ureteral reflux, you would have a incompetent valve, and that would allow the backflow of urine from the bladder back into the ureters. And this could also cause increased pressures in the ureters and the kidneys, which would also predispose to hydronephrosis or hydroureter. And I've talked more about that condition in a separate video, so you could reference that video if you wish. All right, so now we're going to look at the gross and the microscopic pathology of acute pyelonephritis. So the hallmarks, we would have patchy interstitial suppurative inflammation, intratubular aggregates of neutrophils, neutrophilic tubulitis, and tubular injury. So just remember that pyelonephritis would typically affect the renal interstitium and the renal tubules. That's important to know. The nature of the suppurations would have discrete focal abscesses or large wedge-like areas, and it may involve one or both kidneys. So this is what a kidney looks like in a patient with acute pyelonephritis. So the cortical surface shows grayish-white areas of inflammation and abscess formation. So in this image here, you could see these whitish areas on both kidneys would be sites where the abscess formation is occurring. All right, so for the microscopic pathological features of acute pyelonephritis, you will see neutrophilic exudates within tubules and interstitial inflammation. So in this image here, you could see this is a hematoxylin and eosin section taken from the kidney in a patient with acute pyelonephritis. So you could see here that there's a large abundance of neutrophilic exudate in the tubules of the kidney, and also in the renal interstitium, you could see an abundance of white blood cells being present here. All right, so the polyoma virus nephropathy is a special form of pyelonephritis, so it's worth talking about it. So a viral pathogen causing pyelonephritis in kidney allografts is polyoma virus. Immunosuppression of the allograft recipient can lead to reactivation of latent infection. So it's characterized by tubular epithelial cell nuclei leading to nuclear enlargement and intranuclear inclusions visible by light microscopy. And this results in allograft failure in about 5% of kidney transplant recipients. And the treatment would consist of a reduction in immunosuppression of the recipient. And of course, we would have to weigh the risk versus the benefits of withdrawing immunosuppression and weigh it against graft rejection and so on. All right, so these are the microscopic pathological findings you would find in this condition. You would see enlarged tubular epithelial cells with nuclear inclusions and interstitial inflammation. So in this hematoxylin and eosin stain section taken from a patient with polyomavirus nephropathy, you could see the tubular epithelial cells here have these nuclear inclusions, which are typically representative of viral infections. And also you could see there's widespread interstitial inflammation present in the kidney. All right, so these are the clinical features of a patient with pyelonephritis. So in acute pyelonephritis, there's a sudden onset of pain at the costal vertebral angle. So this is usually detected on physical examination, also known as the kidney punch test being positive and costal vertebral angle tenderness. And the patient may also have systemic signs of infection, things like fever, malaise, chills, and vomiting. So the patient is going to appear very sick. Indications of bladder and ureteral irritation. So the signs that a patient would have UTI also. So like burning of urination, dysuria, frequent urination, urgency in urinating. That may point, all of these things may point towards pyelonephritis. When doing a urinalysis, you may find the presence of many leukocytes, so a high white blood cell count in the patient's urine. You're going to see leukocyte casts. You're going to see it being rich in neutrophil pus casts, which may indicate renal involvement rather than a lower urinary tract infection. The diagnosis would be established by quantitative urine culture, which may isolate the organism causing the pyelonephritis. All right, so in terms of imaging for pyelonephritis, we don't typically always do imaging for patients with acute pyelonephritis. Reasons why we would do imaging is if a patient is being treated for pyelonephritis, but they are not, their symptoms and their condition is not resolving. So in those cases, we may want to do imaging on the patient to look for any complication, like they may be developing a perinephric abscess or renal abscess, which may be the cause of them not responding to treatment. And those are some typical reasons why we would want to do imaging. So CT scans are really good in visualizing the kidneys. So in acute pyelonephritis, you may see the perinephric fat stranding. So this could be seen here on this CT scan image. In a patient with pyelonephritis, acute pyelonephritis, you can see here there's swelling of the fat that surrounds the kidney as a result of inflammation that's present in the kidney that causes the perinephric fat stranding here. And you can see the kidney appears, the parenchyma of the kidney appears a bit striated. That's also characteristic in a patient with acute pyelonephritis. All right, so if you need to treat pyelonephritis, the treatment approach would be antibiotics, the mainstay of treatment, analgesic for pain control, and antipyretics for temperature control. Empirical antibiotics are given and is adjusted based on the culture result from the patient. Patients typically respond to oral antibiotic therapy and can be treated on outpatient basis. Um, Imaging is often unnecessary for uncomplicated cases, and intravenous antibiotics is only required if a patient develops complication, needs to be hospitalized, and they have the complications of acute pyelonephritis, especially if it's not resolving or the patient is either immunocompromised or have some sort of other comorbidity. All right, so these are some complications of acute pyelonephritis if untreated or inadequately treated. So abscesses are a major concern, and the abscesses could be located in various anatomical locations, and we could use this image to look at where the abscesses may be. So first, the outermost part, you would have the perirenal abscess, also known as perinephric abscess, which would be within the patient's Gerter's fascia, also the renal fascia. So that would be outside of the kidney, really. Then we could have a subcapsular abscess, which is just below the renal capsule. That's why it's subcapsular. And we could have an intraparenchymal abscess or a renal abscess, which is going to be inside of the renal parenchyma below the renal capsule. So complications if a patient would have recurrent episodes of acute pyelonephritis that could cause chronic pyelonephritis, renal abscess as we mentioned. A perinephric abscess could also lead to a psoas abscess because of the most external um, location of this type of abscess and the presence, um, the proximity of the psoas muscle relative to the kidney. Renal papillary necrosis is also a concern. Emphysematous pyelonephritis and urosepsis. Sepsis could occur, and that could be very life-threatening for the patient. Alright, so now we'll end this lecture by talking a bit about chronic pyelonephritis. So this is characterized by chronic tubulo-interstitial inflammation and scarring involving the calyces and the pelvis of the kidney. Pelvocalceal damage is distinctive and important for diagnosis. Chronic tubulo-interstitial arterial are seen in various diseases, but in only chronic pyelonephritis and allergic nephropathy would affect the calyces of the kidneys. So the clinical importance of this is the recognition of pelvocalceal damage aids in distinguishing chronic pyelonephritis from other renal disorders. So this is an important point in your differential diagnosis to differentiate chronic pyelonephritis from other causes of renal disease. So this is a typical course of chronic pyelonephritis associated with vesicoureteral reflux, where we would see blunted calyx, as you could see here, and scarring on the kidney. All right, so now let's look at the gross pathologic features of a patient with chronic pyelonephritis. So the hallmarks of chronic pyelonephritis are coarse, discrete corticomedullary scars overlying dilated, blunted, or deformed calyces and flattening of the papilla. So on this diagram here, you can see this is the outer surface of the kidney of a patient with chronic pyelonephritis. And you can see here the scars present on the surface and the deformities present. And if this kidney was sectioned to see the papilla and the calyces, you could see that there's flattening of the papilla and there's deformed calyces here. So the scars vary from one to several, and most are in the upper and lower poles, consistent with the frequency of reflux at these sites. Alright, so now let's look at the microscopic features of chronic pyelonephritis. So just like in acute pyelonephritis, you're going to see the tubules and the renal interstitium being affected. The tubules going to show atrophy in some areas and hypertrophy or dilation in other areas. You might see dilated tubules with flattened epithelium, and the tubules may be filled with casts resembling thyroid colloid. So this is referred to as the thyroidization of the kidney because it looks like the microscopic section taken from the thyroid gland. And you might also see varying degrees of chronic interstitial inflammation and fibrosis in the cortex and medulla. So I want to emphasize more on the thyroidization of the kidney. So The tubules are filled with this very eosinophilic material, and that material is basically casts from white blood cells, and they make the kidney dissections appear like thyroid tissue because it resembles the follicles of the thyroid, as you could see here, and if you compare it to thyroid tissue. All right, now let's look at xanthogranulomatous pyelonephritis. So this is a condition present in your first aid for the USMLE, so that's why I included it here. And it's characterized by accumulation of foamy macrophages intermingled with plasma cells, lymphocytes, polymorphonuclear leukocytes, and occasional giant cells. So this is a section taken from a patient with this condition. And here you could see these large cells are giant cells, which has many nuclei, very characteristic of this condition, and granulomatous infections in general. And this condition is associated with the proteus infections, and it may produce large yellow, orange nodules, granulomatous tissue containing foamy macrophages. And the gross appearance may mimic renal cell carcinoma. So this is a gross section of a kidney taken from a patient with this condition, and you can see these large cystic spaces, and it may mimic, it may be very suspicious of cancer, but it's actually a benign condition. All right, so I would like to reference the Robbins and Coran pathological basis of disease, which was very instrumental in making this lecture. And thank you for watching, and I hope you found this video very helpful. If you like my work and you like this video, please give me a thumbs up and subscribe to my channel for more video like these, and I'll see you in the next video. Goodbye.